Hi, my name is Kayla, and I'm a student nurse practitioner at United States University Family Nurse Practitioner Program. And I am going to be reviewing a case study with you about a patient I had recently in clinic who presented with difficulty breathing. So recently in clinic, I had a 70-year-old white female present to the clinic with a chief complaint of, "I'm having difficulty breathing." Those were her exact words. "Having a hard time breathing." She reports progressive worsening of wheezing, shortness of breath, and cough over approximately the last 3 months, with symptoms beginning in April. And when we took this report, it was June. She states that her symptoms have become severe enough to interfere with both her daily activities and sleep. She experiences wheezing both with exertion and at rest. And she's also reporting rib pain during episodes of severe wheezing. The severity is intermittent, though, and not with all efforts of exacerbation or, of exertion, but it is prevalent enough that it's inhibiting her ability to do her daily activities. She describes difficulty taking deep breaths as well. She's stating that she can only take shallow breaths because it does hurt that intercostal rib space. At home, she is monitoring her O2 saturation, and it ranges anywhere from 92 to 95 on room air. This patient has a known history of asthma, but reports inconsistent use of her maintenance inhaler because of insurance coverage and financial barrier issues. She also reports limiting her rescue inhaler use, which is albuterol, because she's afraid of running out of that medication for when it's severe, when she has a severe attack. Her past medical history is significant for asthma, hypertension, AFib, type 2 diabetes with neuropathy, stage 3A chronic kidney disease, hyperthyroidism, allergic rhinitis, which is chronic for her, breast cancer, which she's had treated with a lumpectomy and lymph node removal in 2013. And then she also experienced endometrial cancer, which was treated with a total hysterectomy and lymph node dissection in 2022. Her current medications include Waxella, which is her maintenance inhaler, that is not currently being covered by insurance, and is very cost heavy for the patient. And then she's taking, again, the albuterol for her rescue inhaler. So Waxella is her maintenance and albuterol is her rescue. She also takes an assortment of cardiac medications, including losartan, Eliquis, propafenone, Farxiga, and atorvastatin. And then she's taking methomazole or tapazole for her hyperthyroidism. She does have allergies, no known allergies to medications or food. However, she does have seasonal and environmental allergies, especially to dust, is one of her really aggravating factors. She's a lifelong non-smoker and reports very rare alcohol use. We did a physical examination and she was alert and oriented. She was in mild respiratory distress, though, noted by her respiratory rate being of about 20. Oxygen saturation was great, though. It was 97% on room air. Blood pressure was 136/95. Heart rate was 73. And she had a temperature of 98 degrees Fahrenheit and BMI of 32.3. For her pulmonary examination, it revealed bilateral expiratory wheezes with accessory muscle usage during exertional breathing. So like when she walked into the room to the chair, or from the chair to the bed of the assessment bed. There were no crackles or rhonchi, though, on auscultation. And then we did a cardiac examination, and that demonstrated a regular rate and rhythm with no murmurs, rubs, or gallops. And the remainder of her physical exam was largely unremarkable. So, given the circumstances, my primary differential diagnosis was acute exacerbation of persistent asthma. So, obviously, she has a known history of asthma. This is progressive wheezing, cough. She has some nocturnal wheezing symptoms, exercise intolerance, accessory muscle usage, and then evidence of poor control or medication adherence, which is secondary to the financial barriers. So that plays a big role in this primary differential diagnosis. In fact, it could be its own differential diagnosis of, it is intentional underdosing of medication regimen due to financial hardship, which is ICD-Z91, period 120. So that in and of itself could be its own diagnosis, but falls well under this category of asthma exacerbation. According to the Global Initiative for Asthma Guidelines, or GINE, poor adherence to inhaled corticosteroids is one of the strongest risk factors for uncontrolled asthma and future exacerbations. So it genuinely can be a significant factor to her presentation, is the poor adherence to the medication, maybe not just progressive. It's hard to tell at this point if it's progressive or poor adherence. Second differential diagnosis would be congestive heart failure, or what is sometimes referred to as cardiac asthma. Given her age, history of hypertension, AFib, diabetes, chronic kidney disease, obesity, and hyperlipidemia, heart failure remains a really important consideration. Heart failure can also present as shortness of breath or dyspnea, nocturnal symptoms or orthopnea, and even wheezing due to the pulmonary congestion that you can have, so on auscultation. Although she lacks peripheral edema, pulmonary crackles, current ACC and AHA guidelines, heart failure guidelines recommend further evaluation with chest imaging, EKG, BNP, and echocardiogram to diagnose or to rule out the diagnosis of congestive heart failure when a diagnosis is uncertain, which you can definitely say it is in this case. Her third differential diagnosis is pulmonary malignancy with metastatic pulmonary disease. Although she's never smoked in her life, she does have a history of both breast and endometrial cancers with lymph node involvement, which increases concerns for recurrent or metastatic disease. Progressive respiratory symptoms over several months warrant chest imaging to exclude malignancy before only treating this patient for asthma. The diagnostics that we're going to complete for this patient, the number one thing I think that we should do right now to really help us differentiate between cardiovascular, pulmonary, or cancer, right, is to get this chest x-ray ordered. I think it's really helpful to have this imaging in place, both a 2-view chest x-ray, so you're going to get the lateral and the PA, to evaluate for pneumonia, pulmonary edema, malignancy, and other possible structural lung diseases like COPD. And that's another factor. It could be pneumonia. That's another differential diagnosis we didn't even talk about, but it's very possible that with her presentation, there's just so many different things that it could be, and a diagnostic image of her lungs can be really helpful in ruling out a lot of these options or thoughts. I also think spirometry with bronchodilator testing is going to be really beneficial, so we can get a baseline on what her lung function is, but right now isn't the best time because she's currently in respiratory distress. It's a mild respiratory distress. It's intermittent. She's able to speak in sentences and do some activities, but it is starting to affect her activities. So yeah, for right now, we're going to hold off on spirometry testing. However, I think that that's something to come back to, possibly at her follow-up visit if everything is controlled. And then if things that are, if the symptoms persist abnormally, and if the imaging comes back abnormal, I think it's a really good idea at that point to order CT and definitely get pulmonology involved. In fact, I think that it's okay to get pulmonology involved now. Like, I think that she's got enough going on that having a specialist on her case is indicated. For her medications, obviously she's not able to acquire the Oxella, which is the maintenance inhaler that she's taking right now. So we're going to discontinue that. And then in clinic, we actually work with a bunch of reps with different companies, and one of them happens to be Trelegy. So Trelegy is a guideline inhalation therapy that the GYN recognizes. Or the GYNA recognizes. So we are going to transition to that because it's going to help potentially. My goal was that at that time, our goal at the time is that it's going to help contribute to her poor adherence of this medication. She was really limiting herself on her ability to take that medication because she was trying to space it out as much as she can for financial purposes. But having accessibility to the sample hopefully will remove that barrier, both while insurance coverage is being addressed, and then also just so that she can have like this maintenance in the meantime and hopefully have some resolution over this exacerbation. She was instructed to continue using the albuterol, however, as a rescue inhaler as needed. So, of course, when you're starting a new medication, there's a lot of education that is involved. So we want to focus our education on, of course, the proper technique for using the Trelegy device. This also includes the education of making sure that they rinse their mouth. Oral hygiene is really important after using a corticosteroid inhaler to reduce the risk for oral candida, also which is just like an oral fungal infection. So we want to avoid that by teaching them proper oral hygiene. So that's part of our education. And then we also want to discuss that Trelegy is a maintenance medication. So we want to give to you this medication so that you can take care of yourself, and we're not going to charge you for it. However, we do need you to take it every single day. We're removing that financial barrier because we want you to take it every single day. It's really important to make sure that you stay out of this exacerbated state, and part of to keep your asthma from progressing to an even worse point, we need to medicate and maintain it daily. And the Trelegy is the device for that, medication for that. It's not intended for when you're having a flare-up. So if you take the Trelegy every day as ordered, and then if you are having a flare-up, then we use the albuterol. So that is the rescue inhaler. Don't double dose with the Trelegy. It can lead to worsening symptoms. And then also, we want to review the avoidance of environmental triggers and reinforce adherence to daily controller therapy. So again, the Trelegy is the daily controller. And then we review our asthma action plan, including indications for same-day outpatient evaluation, such as increasing rescue inhaler usage. So if you're on your maintenance inhaler and it's doing well, and then all of a sudden you notice you have to use your albuterol more frequently, that's increased rescue inhaler use. So that would warrant you coming into the doctor same day. So outpatient, just come and see us again. Worsening wheezing or declining in exercise intolerance. Those are other reasons to come back to outpatient. However, we also reviewed emergency precautions, such as taking immediate medical care for severe shortness of breath at rest. So while you're resting, if you are having severe shortness of breath, you cannot speak or complete sentences, oxygen saturation is below 90%, you look blue, or if somebody notices that you're confused or having a failure of the rescue therapy to relieve any symptoms, that warrants you to go to the emergency room because you may need more interventions that we can provide you here in outpatient care. We want to see her in 2 to 4 weeks to reassess how her new inhaler is working for her, how her asthma is being controlled, how she's doing the inhaler technique, like if that education has stuck. And then we also want to review the chest x-ray that we're sending her for. She also mentioned when she came in that day that she was going to her cardiology appointment right afterwards, which is great. We encourage her to please keep that appointment because as we saw, one of the biggest learning points from this encounter was how difficult it can be to determine the exact diagnosis for respiratory symptoms. It could be cardiovascular. It could be pulmonary. It could be cancer. You just don't know where it's coming from. And she also has a history of some kidney issues. So making sure that she sees her specialist is really important. And the other factor was also patient variables like adherence to medication or financial barrier is more appropriate in her case, because it wasn't the fact that she didn't want to take the medication, it was that she physically had a barrier where she couldn't obtain that medication to take it. And that is an additional complication in a diagnosis to consider, which is just reinforces that there's a broad range of things that could cause this to be a more progressive asthma exacerbation. This patient, or respiratory exacerbation, because we don't know if it's asthma. There's a bunch of different differentials. This patient is a great reminder of the importance of maintaining a broad differential diagnosis and adopting the principle of when in doubt, refer it out. Because even this early situation where it's like, well, yeah, technically we can handle it in primary care, just because we can handle it doesn't mean we should have to handle it exclusively. It's okay to get pulmonology involved and cardiology involved when symptoms persist despite guideline-directed therapy, especially for asthma. So she was on a medication that was guideline-directed. It's not working. It's getting progressively worse. Why not get the specialists involved? You could wait a couple weeks to see if the medication is the cause. So like she was having adherence barriers. So by giving her new medications, seeing after 2 weeks if it actually works, and if it doesn't, then refer out. You can wait that, but you can also put the referral in now because it takes weeks to get appointments anyways. So I think that when in doubt, refer out, and you can always refer sooner. It's actually the guidelines for asthma treatment recommend early referral. Early referral to pulmonology when symptoms persist actually improve patient outcomes and ensure potential serious conditions are not overlooked. So it's okay. It's okay to put in the referral now. We don't have to be experts. We just have to be the assisting, like the gateway to the medical community. We could put in those referrals to make sure that these specialists, these patients can be seen by specialists. They're also this patient was also a really great reminder, to just remain human in practice. You never know what people are going through. And adherence to medication isn't always because the patient doesn't want to do it, but because they simply can't afford it. There are realistic barriers, to accessing things in the world, and patients come in and you don't know where they're coming from. And it's really important that we remain human in practice and not blame our patients for not adhering to treatment, because maybe there's something more to it than we're understanding. And the best thing that we can do is listen to our patients and hear them out, hear their concerns, and really center our care around that patient, and help them achieve their goals, like meet them where they're at. So if they're not able to get the medications, let's get creative with them. Let's find ways to help increase access to care, because our goal at the end of the day is just to make sure that our patients are safe and healthy and taken care of well.